Everyone, thank you so much for being here and welcome to our webinar about mental health and ableism. We wanted to start off with a land acknowledgement. This is a statement that's been adapted from the UCSD Intertribal Resource Center, and it reads, UCSD resides on unceded territory of the Kumeyaay Nation. The UCSD community holds great respect for the land and the Indigenous people that first resided where we are currently located. Furthermore, we want to acknowledge that the Kumeyaay people continue to have political sovereignty and cultural traditions as vital members of the San Diego community. We acknowledge and continue to amplify and uplift the Kumeyaay Nation for their contributions to the UCSD community and greater San Diego community. And you can see on the right is a map of Kumeyaay lands. And if you'd like to learn more about the Kumeyaay Nation, you can go to www.kumeyaay.com. We also wanted to introduce ourselves. So hello, my name is Reese Cicilline. I use she, her pronouns, and I'm one of the outreach and engagement interns at the Cross Cultural Center, as well as a social justice educator.
Hi, everyone. It's so nice to be here with you tonight. My name is Amberly. I use she, her pronouns, and I'm one of the affiliates and leadership interns, as well as a social justice educator. Feel free to introduce yourself in the chat if you would like. While people are introducing themselves, we will talk about the community guidelines set for this presentation. This is a brave space, meaning that some of these topics that we will be covering tonight are heavy and could be emotional. However, we respect and recognize that this is where learning takes place. And because of this, make sure to respect everyone's different viewpoints and different lived experiences that they bring into this space, and also recognizing the diverse ranges of knowledge that we all have. Here is a table of contents for our presentation tonight. First, we will be doing an overview of what ableism is and examples pertaining to mental health. Secondly, we will be talking more about mental health in particular, the history behind it, what it entails, and mental illness, as well as neurodiversity. Third, we will be talking about current problems, including mental health institutionalization, policing, inaccessibility to treatment options, as well as other topics. And then last, we'll be talking more about some solutions as well as resources and ways to increase access to care and also to help combat ableist policies. We wanted to start with the section on what is ableism. And before we start with a formal definition, I wanted to hear from you all. Here's a check-in question, and feel free to type in the chat. Make sure your settings are to everyone. And the question is, have you ever experienced a situation in which the room you were in or the activity you were doing was not accessible to everyone? While people are typing in responses, one example that I can think of is my great aunt. She uses a wheelchair, and on our last recent trip to visit her for Thanksgiving, we were unable to go to this particular restaurant because there was no ramp access for a wheelchair. Hi, everyone. Thank you for your responses. Hi, Michaela. Hello. Oh, that's a good point. Concerts or movies. Yep. For sure. Lots of like flashing lights and loud noises. Excellent. Thank you everyone for your responses. We will continue to move on, but as always, feel free to add as we continue. Here is a formal definition of ableism by the Center for Disability Rights, and it reads, a set of beliefs or practices that devalue and discriminate against people with physical, intellectual, or psychiatric disabilities. There are several different forms of ableism, including institutionalized ableism as well as internalized ableism. However, for our presentation tonight, we'll be focusing mostly on mental ableism. And here is a 3-minute YouTube video by participant talking more about ableism specifically.
I feel so blessed to be able to just live my life and have people be motivated by it.
I have a spinal cord injury. And so when I was seeing people roll by, I was like, wow, so that's what I'm gonna look like.
I think I'll do a bit of it. I think it's cancer and kids.
I was born paralyzed. I was born with spina bifida. So I've been paralyzed my whole life, and it's the only life I know. So I had to kind of grow into learning I was different.
My biggest insecurity is my legs. So I decided, hey, if that's my biggest insecurity, then I'm gonna start a gene line. And all of the pictures are based around my jeans and my legs and other people's legs. And that's where I realized that it's okay to be different, because once you embrace it, your entire world changes.
People need to, they're allowed to react to me a lot of times. So like, I make little jokes like, hey, calm down, it's okay. I'll be okay.
I would have people treat me as if I wasn't really there, and I would have people treat me like they didn't want anything to do with me. And perhaps it's because they were scared and they didn't know any other response.
One of my favorite things is when I'm out in public and I have all my girls with me who are all in chairs, who are all gorgeous. And we literally love when we see heads just turn.
Society doesn't correlate disability and being attractive. We are beautiful people. Everyone's beautiful in their own way, but we can be stylish. We can be gorgeous and stunning and fabulous, as I like to say, because yes, I see myself as being fabulous.
Being a dancer, you know, once a dancer, always a dancer, I didn't stop. So I would go out to the clubs and I would get my boogie on. And I was surprised by how guys would approach me and be like, hey, you're hot. And they wouldn't say, you're still hot. They would say, you're hot.
There is the black and white. There's the bad and there's the good. So as long as you're focusing on the good, then the bad just seems to melt away.
We're only given one life, and you gotta be proud of it.
You want to bust a couple of moves? Oh.
Perfect. Let's get a cut.
All right, thank you everyone for your attention during that video. We also wanted to highlight some more examples of ableism that can be seen in everyday life. First of all, we have language. So commonly used words such as crazy or dumb can be very harmful and perpetuate stereotypes against people who have mental illnesses or conditions. A second example would be with places and buildings, such as buildings not having signs put up for the name of the location in Braille. And another example would be with transportation, including inaccessible subway routes, as well as lack of alternative routes for events. A recent study done in 2017 showed that in New York specifically, over a third of their subway stations were deemed inaccessible to people with wheelchairs, which is significant because subways and buses and other main public routes of transportation are frequently utilized in order for people to get to work and to important events. And so if they are inaccessible, that can have lasting consequences on people's economic and job security as well. Our second section will be focusing more on mental health. So what makes up mental health? A definition for mental health is one's emotional, psychological, and social well-being. And there are so many different factors that go into one's mental health, including biological ones, your life experiences, your also as well as your family history of mental health problems. Mental health is something that can be can fluctuate just like someone's physical health, and it is made up of so many other factors, including environmental ones as well. And another common one is like displacement off of your land if you are a refugee, if you are experiencing houselessness, that can further exacerbate mental health conditions, as well as several other important factors that happen in one's life. Now for some key terms. So mental illness refers to medical conditions that impact thinking, feeling, and functioning. And an important note is that mental illness can affect anyone. Currently in the US, 1 in 5 adults are experiencing a form of mental illness. Specifically, 42% of Americans are experiencing depression and or anxiety. So this is something that can happen to anyone at any time. And it is not a weakness of character by any means. It is determined by so many other external forces and structural inequities at play. And then for mental ableism, this refers to discrimination against individuals with neurodivergent disorders and or mental illnesses. And we'll be talking more about specific examples of mental ableism in the next few slides. So some specific examples include not allowing students testing accommodations. This can be seen in professors or teachers refusing to give students more time to finish assignments and or tests. Another example is single format teaching and learning. There are different ways that people prefer to learn, such as kinetic learners who prefer to learn through movement. There are visual learners, auditory learners, and reading and writing learners. And so if a professor or teacher chooses to stick to only one modality of learning, this can negatively impact other students' experiences who depend more on one version or the other. And then another example is blaming someone for their mental illness, saying that it is their fault, or to try to look on the bright side, or that it could be worse, is really harmful and is from an ableist ideology, because it is singling out the person who is experiencing a mental illness instead of looking at the bigger structural forces at play. Another really big example is with lower hiring rates. Currently in developing countries, between 80 to 90% of people with mental illnesses are not being hired by companies due to the discriminatory practices in terms of the interview process and also the company's standards. Specifically looking in education, there are some big examples such as 504 plans not being granted and respected. 504 plans refer to Section 504 of the Rehabilitation Act of 1973 that was passed by the US Congress. And this plan is specifically in place to prevent discrimination against people with disabilities in schools. However, there's no federal funding available for this program. And so it is up to schools to try to advocate for this funding and to give to students. So there's a lot of inequity at play in terms of which schools receive the funding. And current studies have shown that across the US, it is more, white students are twice as likely as other students of color to have access to 504 plans, which is a really big disparity. And then also another example of a learning plan in place for students with disabilities is the IEP, or individualized learning plans. These are more comprehensive and are specific to certain mental conditions, such as autism and others. But a lot of schools still do not have access to these plans, and it can be expensive as well as very time consuming for the schools to implement. And so there's not enough resources on a national level to help schools implement these for students. And then another example is with colleges choosing not to invest in comprehensive psychiatric resources and trained counselors. So a recent study shown by the National Council on Disability talked about how 47% 47% of respondents said that lack of the funding was the main reason why their college did not have comprehensive resources, as well as this is a huge problem because in 2019, a study showed that 30% of 18 to 25-year-olds in college are experiencing a mental illness. So this is a really significant problem because college students are usually typically in like the young adult range of 18 to 25. And so for this to be a big problem within that age range and not having enough resources at the college themselves is a problem. Moving on to a discussion on neurodiversity. This is a phrase that was coined by sociologist Judy Springer in the late 1990s. And its definition is the recognition and celebration of the variations of cognitive functioning in people. This is an approach that is trying to get rid of the binary of normal and abnormal in terms of mental ability and intelligence. And so it is more of a celebration of all of our different abilities and comprehension levels and intelligence instead of trying to portray mental illness as a negative thing. So some examples of neurodiverse conditions include ADHD or attention deficit hyperactive disorder, autism, dyslexia, and many others. And so once again, this is a way in which to combat ableist ideas against mental illness, to be more of a celebration and recognition of all of our different abilities. A note on neurodiversity is that 10% of the current human population is considered to be neurodiverse.
All right, so now we're going to talk a bit more about current problems surrounding mental health and care and ableism. So I wanted to start off with the history of mental health care because I think this provides an important groundwork and some framework to understand where we are right now. So we'll start off pre-1800s. Before this point, there were really no resources for people with mental health issues in the US. Now, this changed around the mid-1800s. This was when the number of psychiatric hospitals began to grow. But at this point, any sort of community-based mental health care was essentially unavailable. Now, institutionalization grew until around World War II, so around the 1940s. And at this point, stories began coming out about how inhumane treatment in psychiatric hospitals was. So then in the 1950s, specifically in 1950, the first antipsychotic was developed. And this represented a beginning of a shift to community-based care, where people could receive mental health care from the comfort of their own homes, as opposed to being institutionalized. And then after this point, institutionalization severely declined from around 1955 to 2005, with big thanks to social movements. So different social movements that were impactful to this were the civil rights movement from the 1950s and 60s, the community mental health movement in the 1960s, the evidence-based practice movement in the 1980s and 90s, and then the recovery movement also in the 1980s and 90s. And additionally, grants for community-based services, including later Medicaid coverage of mental illness, was helpful in deinstitutionalization. So I want to talk a bit about what institutionalization was and why it was an issue. Institutionalization initially began with good intent, the intent of having psychiatric hospitals as the place where people could receive mental health care was based around an idea called moral treatment. And this idea was to give patients personalized treatment and attention and making sure to treat them humanely. So for example, having no physical restraints and working in this setting to improve social skills, self-control, and self-worth. However, the Industrial Revolution led to an increased need for mental health care. and the number of mental health institutions increased drastically. It increased almost 10 times throughout the 1800s, reaching 150,000 by 1904. And because of this, there was a significant lack of resources and not enough funding to keep up with the increase in the number of patients. Another thing that was present during this time was pseudoscience, so science that wasn't based in any sort of evidence or real fact. Some examples of this include eugenics, which is the theory of racial improvement and a planned breeding to create a superior human race. And another example of pseudoscience during this time was phrenology, which was the idea that the shape and size of bumps on the skull could be used as a predictor of mental traits. Now, both of these have been shown countless times to not be true and have no real evidential basis. However, at the time they were used, and this led to horrible treatment of patients, including things like forced sterilization. Additionally, doctors would also turn to many severe treatments to treat mental health issues. So things like electroconvulsive therapy, also known as ECT, was used, which induces seizures through electrical shocks. Lobotomization was also a practice that was used, which severs connections between the prefrontal cortex, so the front part of your brain, and then the rest of your brain. And of course, these practices were very controversial because they had varying and sometimes extremely negative effects. Another part of institutionalization that was quite negative was the treatment in psychiatric hospitals. Patients were not treated well. They oftentimes were not given mental health treatment, and it became just sort of a holding place for people with mental illness. As mentioned before, because there were so many people who needed care, there was overcrowding. People would be put in restraints, secluded from each other. They were sometimes starved or faced physical abuse, and people even died in these psychiatric hospitals. So this video I'm going to show is called Deinstitutionalized, and it was created by Core Media, and it explains a bit about the process of deinstitutionalization and starts to help us understand where we are today. So this video is around 5 minutes long, and I just want to give notice before it's played that there are some disturbing images in this video, such as people in prisons and in negative interactions with police.
The epidemic of chronic homelessness in America is connected to the deinstitutionalization of the severely mentally ill from state psychiatric hospitals in the 1960s and 70s. Many of these policies were intended to improve the lives of those living with mental illness, but in practice, they have left severely mentally ill patients in a vicious cycle of homelessness and incarceration. This is the story of how we got here. Beginning in the 1800s, severely mentally ill patients were forced into large, state-run psychiatric hospitals.
Electroshock therapy, prescribed by the psychiatrist and administered by the physician, is a well-known method of bringing the patient back to reality.
Reporter Albert Deutsch published The Shame of the States, a horrific account about the conditions of state mental hospitals in the 1940s. Deutsch's expose sparked public outrage and demands for a different approach to mental health treatment. In the 1950s, Thorazine is approved by the FDA. This was the first drug used to treat severe mental illness. As drugs began to replace debilitating and brutal procedures like electroshock therapy or lobotomy, doctors and policymakers saw an opportunity to use drugs like Thorazine as a way to treat patients outside the setting of a hospital.
Again in the Senate this week on our bills to combat mental illness and mental retardation. Almost every American family at some stage will experience or has experienced a case of mental affliction, and we have to offer something more than crowded custodial care in our state institutions. Our task is to prevent these conditions. Our next is to treat them more effectively and sympathetically in the patient's own community.
In 1963, President John F. Kennedy signed the Community Mental Health Act into law. The act moved the responsibility from state facilities to federally funded, locally based treatment. This was the beginning of deinstitutionalization. Less than a month after signing the bill into law, President Kennedy was assassinated, leaving the Community Mental Health Act never fully funded. In 1965, as part of the War on Poverty, Congress establishes Medicaid and Medicare. People with severe mental illness living in psychiatric hospitals are not eligible for the benefits of these new programs. In 1967, California Governor Ronald Reagan signs the Lanterman-Petris-Short Act, known today as the Patient's Bill of Rights, which ended the practice of institutionalizing patients against their will for extended periods of time. During the years that followed, California psychiatric hospitals emptied by over 50%. Instead of seeing more mentally ill people in group homes, California began seeing them show up in county jails and state prisons. Finally, in 1981, the U.S. government passed the Omnibus Budget Reconciliation Act, which cut federal mental health spending by 30%. Left with insufficient federal funding and no state responsibility for mental health treatment, American cities have paid the price. Today, the United States has unintentionally criminalized mental illness, pushing the burden of mental health treatment onto our criminal justice system. The goal of deinstitutionalization was to use existing resources to help those suffering severe mental illness to live in the community instead of inhumane hospital conditions. But the reality is that these community-based solutions have never been adequately funded, and being poor and mentally ill require a complicated support system. If we want to fix the epidemic of homelessness in San Francisco, we need to invest in our mental health infrastructure.
All right, so I'm going to talk now about one of the issues, and this is the inaccessibility of mental health treatment in the US. So first of all, it's important to note that nearly half of people with mental health conditions in the United States go without care. You can see in the pie chart on the left that a significant number of people are not receiving treatment for mental health issues, more than who are receiving treatment. And this is for a couple of reasons. And there are many different factors, of course, but the four main ones I'll be talking about are financial barriers, a lack of mental health professionals, lack of care facilities, and racial barriers. So for that first one, financial barriers, it can be really difficult for people to afford mental health care. Even if you have insurance, it can be difficult to find care that works for you that's within your insurance network. Additionally, many private mental health hospitals don't accept insurance, and without insurance, they can cost more than $30,000 a month. Also, Medicaid is the only path to mental health care, but there's a provision in the Medicaid law that doesn't allow for long-term care. So financial barriers are very significant in keeping people from being able to access the care that they need. Another reason why treatment for mental illness can be inaccessible is because of a lack of mental health professionals. There's a shortage of mental health care providers, especially in rural areas. Another issue is a lack of care facilities. There's a severe shortage of inpatient and long-term care options due to the deinstitutionalization that we talked about. And additionally, we often wait for a big issue to come up in mental health treatment, so a crisis to happen before people get any sort of care. Further, many people experiencing mental health crises end up in emergency rooms, and these environments are often unwelcoming, unfamiliar, and scary. These hospitals can also only care for people for 72 hours. So after that point, they're not receiving the care that they need. Instead, we need to have a continuum of care. So care before, during, and after any sort of mental illness or mental health crises. And I'll talk a bit more about how a continuum of care can look in a couple slides. Another important barrier to recognize is the racial barrier to mental health treatment. Now, white people are the only group in the United States where the majority of people with mental health issues can get care. And this is especially an issue for Black individuals. Whereas other racial groups have seen growth in their ability to receive care, there has been no change for Black people. Furthermore, physicians and care providers can be discriminatory, resulting in a lack of care or poor care for people of color. This next slide shows a graph of who is able to receive mental health services. And you can see a significant difference from people who are white identifying and people of color. So for example, American Indian or Alaskan Native, Black or African American, Hispanic or Latino, Asian, and Native Hawaiian or other Pacific Islander all have much lower rates of accessibility to mental health treatment than white people do. So it's clear that there's a racial divide in this. Another issue that I wanted to talk about that's important to consider when we're talking about mental health treatment is mental health and houselessness. As the video addressed, these two things are very much linked. Houselessness rates in the United States are high and increasing. The Department of Housing and Urban Development found that approximately 580,000 people in the United States are experiencing houselessness on any given night. Additionally, when we talk about houselessness and mental illness, rates of mental illness in people experiencing houselessness are twice those of the general population. According to data from the 2015 Annual Homelessness Assessment Report, over half of adults living in permanent supportive housing had a mental disorder or co-occurring mental and substance use disorder. Now, it's also important to note here that mental illness doesn't necessarily cause houselessness. There are other factors, things like trauma, poverty, a lack of social support, and many other things that play a role. However, people with mental health issues tend to be more susceptible to factors that cause houselessness, things like poverty, isolation, and personal vulnerability. Additionally, in hearing about the lived experiences of people experiencing houselessness, it seems clear that being houseless doesn't help already existing mental health issues and may cause new problems to emerge. A woman experiencing houselessness that I interacted with once was asked by someone else if she had any mental health issues. And what she said was something along the lines of course, if you don't have them before you're homeless, you'll get them on the streets. When experiencing houselessness, your basic needs aren't met, and this is stressful and damaging. Additionally, when experiencing houselessness, there are other issues that can occur, such as sleeplessness and abuse. Just giving people who are experiencing houselessness access to housing and employment are oftentimes not enough to lift someone out of this cycle of houselessness because these other factors play a role. Untreated mental illness and substance abuse can make it difficult for people to keep a job and housing. Instead, long-term, comprehensive, and social support is needed to address houselessness and mental health issues. Another thing to consider when we're talking about mental illness and ableism is policing. There have been countless instances of police brutality and killing of people experiencing mental health crises. Nearly 50% of police victims are living with a disability, and this is usually a mental health one. However, when someone's experiencing a mental health crisis, it can sometimes be difficult to know what to do. And 911 is sometimes the only option for people who need mental health intervention. So family members will call the police looking for help, but the result is a violent or a deadly response. Now, this is in part because police are given little to no training on how to handle mental health crises, and they often resort to unnecessary force or violence. Furthermore, police have weapons and the ability to use deadly force with little consequences, which can result in very negative situations when they come to address a mental health crisis. Now, mental health and policing leads into an important discussion about mental health and incarceration. The percentage of people with serious mental illness in prison has drastically risen over time. And right now, 37% or more than 1 in 3 people in prison have been diagnosed with a mental illness. And 1 in 4 people in jails are experiencing serious psychological distress. Furthermore, in the prison system, there's little to no help for people with mental health issues. 66% or 2 in 3 people in federal prison reported not receiving any mental health care while they were incarcerated. To make matters worse, incarceration can trigger and worsen mental health issues. Incarceration removes people from society and their social networks. It aims to eliminate meaning and purpose from their lives and creates a lack of autonomy, among many other things, which all contribute very negatively to mental illness. Furthermore, prisons often have terrible conditions, things like overcrowding, solitary confinement, and routine exposure to violence, which result in negative effects. People with mental health issues are also often treated worse in prison, that they're punished for their actions that are a result of untreated mental illness. So this just makes matters even worse.
We now have a video done by Now This on YouTube titled How Our Prisons Prey on People with Mental Illness. It is about 3 minutes long.
Incarceration has little to do with if you've done something bad, if you've broken a law, because we all have. We live in a society that has forgotten how to forgive. Incarceration is an experiment, and it's an experiment that has failed. My brother was criminalized from a teenager. He was put inside juvenile halls, he was put inside youth camps, and then eventually put inside the Los Angeles County jail system when he was 19 years old. The system was never looking at him as someone who should get care or should have their dignity. The system always had a target on his back. He was brutally beaten by the sheriff's department, and when he came home from Los Angeles County Jail and also California State Prison, he wasn't better. He was actually worse. He was diagnosed with schizoaffective disorder, and this really moved me to want to do something about what was happening here in Los Angeles. My brother Monty is not an anomaly, unfortunately. We don't actually think about putting people who are sick in jail unless they have a mental illness. We criminalize people who are dual diagnosis, people who have drug addiction and mental health issues. Instead of getting to the root cause, we have to invest in the communities that are most at the margins. People with mental illness, they don't need a jail cell. They need a hospital. They need a mental health clinic. And most of all, they need housing. People who have mental illness who are incarcerated inside of jails and prisons are treated really badly. They are the first ones to be brutalized, not just by guards and deputies, but also by other prisoners. They are often not given the medications that they need, or they're over-medicated. They are not in a therapeutic setting. They're not in a supportive setting. And what it creates is an environment that really fosters PTSD, post-traumatic stress disorder. So when people come home, they are not just dealing with the illness that they were diagnosed with, they're also dealing with the PTSD and the trauma from being incarcerated. part of what we need to think about is it's not really an improvement of the prison system, it's actually an improvement of alternatives to incarceration. We really should be developing a place where we're focusing on community-based treatment, community-based care.
All right, so after watching this video, we wanted to hear your thoughts. So please feel free to type in the chat. What is your reaction to this video? How are you feeling about it? What are your thoughts? I think the first time that I saw this video, I was really struck by the experience that Monte had while he was in jail and how his conditions were exacerbated after undergoing severe brutality and beatings by the guards. And I think also this video highlights hope in how we can move forward with community investments and alternatives to incarceration.
I can respond to this as well. I remember the first time seeing this video, I felt like it kind of brought it all together a bit for me, because I think it helped me understand, the links between incarceration and mental health and how houselessness also plays a role. But also, besides, a very important highlight of the issues, I think it makes me excited to look into what are ways that we can turn to community-based care for mental illness instead of incarceration.
Sounds good. We will start to move on, but feel free to add to the chat if you would like.
So as I mentioned, that video made me really excited to look into other solutions that we can talk about when we're talking about mental illness care. And so this next section will be talking about solutions and resources. So first, I want to focus on mental health and houselessness. This is an overview of a possible way that mental illness can be treated for houseless individuals. So this is an integration of substance use and mental disorder treatment with homelessness services from the Substance Abuse and Mental Health Services Administration Advisory. I mentioned earlier how important the continuum of care is, and this is one way that it can look so that people are getting the care they need throughout this whole experience. So in this layout, the first step is outreach and engagement, which is building relationships with people experiencing houselessness and people who have substance use and mental disorders. Then, once an individual accepts care, treatment, housing, and other services, they start the transition to intensive care. In this intensive care and treatment, they are a part of a clinic, shelter, outpatient, or residential treatment program. And people make sure that the individual is aware of housing resources as an important part of this process. Additionally, comprehensive healthcare services are provided. After this point, they can transition to ongoing rehabilitation. Now, this can be a difficult phase, and it's where relapse or dropout can occur, but this can be mitigated through building recovery skills, community involvement, and providing transitional housing. And then after this point is ongoing rehabilitation, where an individual is no longer experiencing houselessness and is actively working to maintain recovery. And additionally, it's important that in this step, there are regular follow-ups. So I think this is a good overview of a way that healthcare and mental health care specifically can look for houseless individuals so that it's a comprehensive and community-based process. Now, there's some action being done to combat houselessness in combination with mental health care in San Diego, and these are just two examples. The first one on the left is the Alpha Project. They provide residential treatment and temporary as well as permanent housing to individuals. And they make sure to utilize practices like trauma-informed care. So mental health is a consideration in this care that they're giving. Additionally, they provide many other services like legal help, employment opportunities, and tenant peer support services. So it's a comprehensive project rather than just providing someone a roof over their head. Another example is Project One for All that was created by the County of San Diego. They provide extensive services, including mental health counseling and housing to people experiencing houselessness with serious mental illness. Turning to mental health and policing, we can talk about some possible solutions. So non-law enforcement mental health crisis teams can be used to address situations where a person is experiencing a mental breakdown or another mental health issue. It's important that community resources respond to these situations, not police. These people would de-escalate and handle the situation in a safe way that results in the person getting the help that they need, not just being sent to jail. Folks who are in crisis are usually not dangerous, but it's just that they have a need that's unmet. They need help, not police. Now, police crisis intervention teams are something that have been used a bit so far to try and fill this need. However, they've only been modestly successful. And I think this demonstrates a need to turn to community care and action rather than relying on police. There's been a pioneer program in Eugene, Oregon to show how this can work. It's called the Crisis Assistance Helping Out on the Streets, or CAHOOTS. And the way that it works is it's connected to the 911 system and handles mental health crisis situations by sending crisis intervention response teams when the 911 call indicates that it's necessary. Turning now to mental health and incarceration. It's clear that incarceration is extremely negatively harmful to mental health. And while we have a carceral system, it seems that it will be difficult to ever get people the real care that they need. It seems that the best approach here is defunding police and prisons and moving those resources elsewhere to community-based care. However, if we're still working within the system that we currently have, there are some strategies that can be employed to lessen the negative effects of incarceration. One of these is the justice system working in collaboration with mental health services. Having mental health professionals in leadership positions is another important step. Additionally, making sure individuals have medication and treatment while incarcerated, and implementing supportive programs and therapies for people when released can all be helpful in this. There has been a successful test program in Florida called the Criminal Mental Health Program that worked to address the link between mental health and incarceration. So this system had a pre-arrest system which trained officers on how to recognize and deal with people with mental illness. Now, although, as I mentioned, this has been shown to not have the most significant effects, I think using a community crisis intervention team here could work instead. And then after this, they have a post-arrest diversion program. So anyone who's arrested for a misdemeanor is released within a certain amount of time if they meet the criteria for having a serious mental illness, and then are transferred to a crisis stabilization unit where they can get treatment. They then take part in a transition program and are given links to community-based services like housing. So, and through this program, recidivism or reoffending, so doing the crime again, has dropped from 72% to 20% for misdemeanors. Another part of this program has been the Competency Restoration Alternative Program. So this includes nonviolent felonies in the post-arrest diversion program, and instead of focusing on restoring a person's competency to stand trial, so they're just their mental ability to be able to participate in the trial process and understand what's happening, this program works to integrate them within the community and give them the treatment that they need. And through this process, charges are often dropped and participants achieved mental competency an average of 52 days sooner. Furthermore, the recidivism rate dropped to just 25% through this program. So this is just one example of the way that program addressing mental health and incarceration can look, but there are many other solutions and suggestions.
So now we wanted to highlight some of the resources that we have here on campus in terms of mental health. So we have CAPS, which is our counseling service here on campus. They have several different workshops as well as discussion groups that are drop-in and are free. There's also lots of additional resources such as Headspace that is free. It's an online and app-based platform where anyone can access meditation practices as well as yoga and other mental health resources. There's also behavioral health services, which is more of a targeted care approach, and this program works in conjunction with CAPS. Active Minds is another resource here on campus. They are a nonprofit, student-run mental health awareness group. They work to advocate for more resources for students on campus, as well as to educate the broader community. Triton's Rise workshops are drop-in sessions that are also free for students and community members and are on a range of different topics, including mindfulness, sleep habits, and others. And mindfulness and meditation at UCSD is also a student-run organization, and they meet weekly for stress and anxiety relieving practices. Here is a QR code to all of our sources and resources that we use throughout this presentation. On this document, there are sources, but also national sources that you can utilize that are free and accessible to people with an internet connection. One that we wanted to highlight was 7 Cups Therapy. This is a free one and is a great way to get immediate care if something is bothering you. It's a confidential and free platform for you to get help. Here are some of our upcoming events for the Cross Cultural Center. We have Explorations in Cowboy Drag happening during week 8 next Wednesday from 6 to 7:30. We have our CalFresh mini clinic happening next week as well from 12 to 3. Then we also have our Centering Community Voices in Public Health presentation happening during week 9 on that Tuesday. And then we have Wellbeing and Basic Needs happening on week 9 on that Wednesday, followed by Abolition Medicine, Transformative and Restorative Practices occurring during week 10 on Thursday from 5:30 to 6:30. So feel free to check us out, and we will have our QR code with all of our sources or all of our Linktree to our social media platforms available for you all. And thank you so much for your time tonight. We really appreciate you being here. Here's our email, website, and Instagram, and feel free to ask any questions in the chat.